Hello, good evening, everybody. Thank you for being understanding. Thank you for understanding. I wanted to watch that debate on yesterday. It was very good, so I'm glad I got to do that. But I wanted to jump on and talk a little bit about the IV drug abuser, how this patient presents to the hospital, why we're seeing such a big influx of that in the hospital these days. What does it mean? What happens to that patient in terms of septic injected emboli if the patient has a diagnosis like that? And what does it mean to have an infective endocarditis? How long are these patients treated? What are the things that we need to watch for when these patients come in and end up in LTACs? So again, thank you just for jumping on. Hey, Tony. Hey, O+4. I see y'all waving. Thank you so much. Well, I wanted to start with saying that IV drug abuse is very, very, very common now, and most of it is because we have an opioid crisis. Unfortunately, some of this is created unintentionally by providers, whether it be physicians or nurse practitioners, but it's mainly happening because patients end up in situations where they require pain medicine. And then in some patient populations, you will see that there's a part of the brain that's triggered that allows them to abuse the drug. And so even when there's no longer a need for the drug, they don't know how to cut that signal off in their brain and they become addicted to the drug. And when they can't get pills anymore because doctors will spot this, then they turn to the streets and they end up as IV drug abusers, unfortunately. Now, that's a certain type of IV drug abuser. And then you have another type where they have had psychiatric issues. Either they have been abused, they have witnessed abuse. There's a lot of different, the IV drug abuser patient is very complex. And predominantly that's because a lot is going on with that patient from a mental to a physical standpoint. So you're not just dealing with somebody that has a medical problem such as sepsis, a physical problem that needs to be fixed, or endocarditis or septic injected emboli, but you also have a patient that has mental issues going on. And a lot of times you just don't realize, even from a nursing standpoint, how many of those patients are in your hospital beds and are contemplating suicide. So I'm not making any excuses about what goes on, but those patients are very sick from both a physical and mental standpoint. So how do these patients present to the hospital? What happens is a patient will come in and they will complain of something like, I'm short of breath, or I have fever, or I have chills, or I've injected and I missed the spot that I was injecting in, and I kept injecting over and over into that spot. So you end up with abscesses in the area. So all of those are complications that brings a patient to the hospital. So what happens? Why is the patient septic when they come into the hospital? Predominantly, we ask a bunch of questions. Are you reusing needles? Are you sharing needles? Are you using tap water? There are good programs out now for these patients who, unfortunately, you're not going to get them to stop using until they commit to stop using and they put it in their head that they don't want to use anymore. So there are programs like the needle exchange program where they can get free needles for free. Clean needles for free, so that hopefully that they're not re-injecting and infecting other people and causing other problems like HIV, like hepatitis C, and then, like all of these different infections you get. So if a patient reuses a needle or shares a needle or mixes their drugs with tap water, there are bacteria. They rise the potential that they have mixed into the drugs some type of bacteria, or if they have a clean needle and they have dirty skin and they're not thinking about cleaning their skin, which they usually aren't, and they inject that needle into dirty skin and a part of the whatever the isolate is or the bacteria breaks off and enters the bloodstream, it travels. Sometimes that's very fulminant. So remember, I talked about patho. It's very important to know your pathophysiology. So when a patient injects into a vein, which they're not going to inject into an artery, they know better. They're going to inject into a vein. You're injecting into a venous system. So this is the side where blood is traveling back to the heart. So when you inject into that system, what they do is they shower the lungs, because one of the first things you do outside of the right side of the heart is reoxygenate that blood via the lungs. So when it crosses over into the lungs, whatever bacteria is present showers the lungs and it becomes part of the vasculature of the lungs, and that's called septic injected emboli. So when a patient says they can't breathe and you start asking specific questions, do you use drugs? Do you reuse your needles? All those things I talked about, then we know exactly what workup to do with these patients. Or if you don't know, you just kind of do the whole kit and caboodle, which includes this because we know there's an opioid crisis. So you see that there's a bilateral pneumonia or a showering of the lungs, a septic injected emboli, the radiologist will know it right off. He will be able to say this looks like a septic injected emboli case. So we know that those patients will probably have some sort of bacteremia because the cultures aren't back yet. Remember, all of this is happening simultaneously. So you draw blood cultures on these patients, but you start them on broad spectrum antibiotics. And I talked about that in my ID lecture, or my ID little quick synopsis. But basically, you start them on broad spectrum antibiotics and you ultrasound the heart. And the reason you do that is because bacteria likes to seed on things. At the first place it lands in the lungs, it showers the lungs. On the valve, it's going to hit that valve. So one of the first valves it hits is the valve that crosses between the left and right ventricle, the right atrium and the right ventricle. So that's the tricuspid valve. That's the most common valve that you will see a vegetation on. So vegetation just means the growth of whatever was showering around in the system and landed in the lungs and kept going has now seated itself on the valve. Now, what are valves? Valves are a one-way valves that keeps blood moving forward. So you don't want blood to keep backing up. So the valves keep blood moving one way. Valves open, it allows blood in, and then it closes back up. So when you have valves doing this and the blood's coming across and there's a piece of bacteria that seeds on the valve, now your valve can't close properly. So now you have a valve that looks like this as opposed to closing. We call that, if it was on the tricuspid valve, we would call that tricuspid regurgitation or tricuspid valve insufficiency, which means that valve cannot do its job any longer because it can't properly close. And so therefore, the blood that should all be moving forward is not completely moving forward, but some of it is backing up, almost mirroring a patient that had congestive heart failure, but they don't have a pumping problem and they don't have a diastolic problem. They have a valvular problem. So a lot of times what will happen is the size of that valve will determine if you need to emergently intervene. The larger the valve, the harder it is, the larger the vegetation, the harder it is to close that valve. But if you have a patient that you can't close the valve and so you're not getting hardly any blood across, that's medical emergency. But you will see so much of this now that cardiothoracic surgery are the guys that handle this, the specialty that handles this, will not touch it unless the patient is imminently dying. And that's even a risk going into surgery. And most of that is because these patients will reuse. They haven't really addressed the true problem. And these surgeries are very extensive and very costly. And I know it shouldn't mean a lot, but what happens is they go back and they use drugs again and they come back with vegetations on the same valve. You can't keep taking these patients to surgery. So unfortunately, that's what happens. So what happens? They come up with a treatment plan. They find out what they're growing, whether it be staph, whether it be Klebsiella, whether it be Morganella margini, or whatever bacteria they're growing. They'll say, you need 6 weeks of antibiotics. But they can't trust these patients to go home with PICC lines because they already have a problem of injecting even without a line. So you can't give them a wide open source to use drugs in because remember, the problem is still there. So they put these patients in the LTACs, long-term acute care hospitals. So the reason that you're seeing more and more patients there is because there is nothing else that we can do but treat these patients, which is the right thing to do. And so you fill up the LTACs with them. And unfortunately, a lot of times I see two things in the LTAC. Either nurses don't think that these patients are sick, because if you joined the nursing world when I did 20 years ago and I worked in LTAC and you saw all old patients, they were deathly ill, they had wounds, they weren't walking around, they couldn't turn themselves. That is not the case anymore. You will see a lot of walkie-talkie patients. They outside, they smoking, and they're really there just for antibiotics, but they have true medical problems now. So be careful with these patients that have vegetations and infective endocarditis because they're very, very, very sick. If you notice, the heart rates are always up, and it's because the heart is compensating for what's going on with that valve, and you don't want to take that away from the patient. But just realize that these patients are sicker than what they look, and a lot of times the other part you'll see is that we tend, and I'm saying we because I am part of the profession, we tend to judge these patients. So I never forget, I had a patient last week. I discharged after 6 weeks, and she was a very, very, very quiet girl, very young girl, very beautiful girl, and she had a lot of mental issues. She had a lot of things that happened in her life that drove her to drugs. But I treat her like a patient, just like any other patient. And I walked in that room every day and she was not very interactive. I can tell she was depressed, but I talked to her every day. And I kind of just got her to trust me. And I'll never forget 6 weeks later when she walked out of the hospital, she cried and she said, I've never had anybody to treat me. The whole hospital, it wasn't just me. The nurses treated her well. I've never had anybody to treat me the way y'all treated me, like a person, and didn't judge me. She said it was so many days that I wanted to kill myself, but y'all gave me a reason to move on. And to me, that was very striking. So what I'm saying is it's hard hard for us when these patients, sometimes they're always asking for pain medicine. It's like being on a hamster wheel. Something's always going on with them. So they're kind of problematic patients in a sense that they're always seeking. But just realize that sometimes they can't help themselves. We have to just remember the oath that we took and maintain the safety of the patient and move on and judge and say, hey, I can't give it to you. And still don't get annoyed with the patient and treat the patient like a patient. So anywho, getting back to the topic at hand, septic pulmonary injected emboli just means that they have showered their lungs with some type of bacteria that has been a result of a dirty needle or dirty skin or something like that. And it's really just emboli all over the lung. That's more like bacteria. And they can make a full recovery from that. Infective endocarditis just means that the patient has a vegetation on a valve. Usually it's the tricuspid valve because of location of where it is, and it's the first valve that's usually seen. And these patients need treatment for 6 weeks for whatever the isolate is. I hope that helped. Does anybody have any questions? Thank you so much. Y'all have a good night.